Every single night, 35 million Americans go to bed with knee pain. Not a dull ache, but sharp, grinding agony that makes climbing stairs feel like punishment and getting out of a chair feel like a major physical achievement. They wake up stiff, hobble to the bathroom, and spend the first 20 minutes of their day waiting for their knees to remember how to bend properly. And here's what makes this a medical tragedy. In 78% of those cases, the knees themselves are not the problem. The damage is real, the pain is absolutely real, but the root cause is somewhere else entirely, and your next orthopedic appointment will not tell you where. I'm going to explain exactly what's happening inside your body right now, why conventional treatment has failed you, and the simple protocol that can begin reversing knee deterioration starting tonight. Subscribe to Dr. Waterling right now and hit that like button. We're building this channel on one principle. The healthcare system makes money when you stay sick, not when you get better. Every subscriber moves us closer to 1,000 and helps us reach more people who deserve answers they're not getting in examination rooms. Most people believe knee pain comes from worn cartilage, arthritis, or old sports injuries. And yes, those factors exist. But I am not talking about traumatic injury right now. I am talking about the silent, progressive knee destruction happening in people who never played contact sports, never had an accident, people who simply woke up one day and their knees had stopped cooperating. Let me be direct with you. If you are over 50 and experiencing knee pain, stiffness in the morning, clicking sounds when you bend, or that feeling like your kneecap is grinding against bone, there is a 4 out of 5 chance that the actual problem is not in your knee joint at all. Here's what's really happening. Your knee is the largest hinge joint in your body. It's designed to absorb force, distribute weight, and move through a specific range of motion thousands of times per day. But the knee does not work alone. It sits between your hip and your ankle, and its function depends entirely on what those two joints are doing. When your hip muscles weaken, particularly the gluteus medius on the outer hip and the hip flexors at the front, your femur, the thigh bone, begins rotating inward with every step. This is called internal rotation. When your ankle loses mobility, usually from years of wearing rigid shoes or from previous ankle sprains that never fully healed, your tibia, the shin bone, cannot rotate properly to compensate for uneven ground. Now here's the physics of what happens next. Your knee sits in the middle of these two bones. When the femur rotates one direction and the tibia is stuck in another, the knee joint is forced to absorb a twisting force it was never designed to handle. Imagine two pieces of wood connected by a hinge. If you twist the top piece clockwise and hold the bottom piece still, the hinge itself bears all the stress. That is exactly what is happening inside your knee with every single step you take. The cartilage on the underside of your kneecap starts grinding against the cartilage on your femur at an angle. That grinding creates inflammation. The inflammation creates pain. The pain makes you avoid movement. The lack of movement weakens the surrounding muscles further, and the cycle accelerates. After 50, this process happens faster because you lose between 1 and 2% of your muscle mass every single year if you do nothing to prevent it. The hip muscles weaken first because they are large muscles that require consistent load to maintain strength. Most people over 50 are not loading their hips properly anymore. They sit for hours. They walk on flat surfaces. They never sprint, never climb, never move laterally. The glutes forget how to fire correctly. The hip flexors shorten and tighten, and the knee, sitting between a weak hip and a stiff ankle, takes the punishment. Here's what conventional medicine does when you walk into an office complaining of knee pain. They take an X-ray. They see some cartilage loss, maybe some bone spurs, and they tell you 3 things. Lose weight, take anti-inflammatories, and if it gets bad enough, we'll talk about knee replacement surgery. That is the standard protocol. I have watched it fail thousands of times over 15 years of clinical practice. Not because the advice is wrong, but because it addresses the symptom while completely ignoring the mechanical cause. Let me tell you about Margaret. She was 64 when she came to my office convinced she needed knee surgery. She had seen 2 orthopedic surgeons. Both had shown her the X-rays. Both had confirmed moderate osteoarthritis in both knees. Both had recommended she lose 30 pounds, try physical therapy, and come back in 6 months to discuss surgical options. She had done the physical therapy. They gave her exercises to strengthen her quadriceps, the big muscle on the front of the thigh. She did leg extensions, straight leg raises, all the standard knee strengthening protocols. Her pain got worse. When I examined Margaret, I did not start with her knees. I watched her walk. Her feet turned outward like a duck with every step. Her hips dropped on the left side when she stood on her right leg. When I asked her to balance on one foot, she could not hold it for more than 3 seconds before her hip collapsed inward. Her knees were responding to a biomechanical disaster happening at the hip and ankle, but nobody had looked there. We did not touch her knees for the first 2 weeks. We worked only on hip strength and ankle mobility. Within 3 weeks, her knee pain had decreased by 60%. Within 2 months, she was hiking again. The system does not profit from teaching you hip strengthening exercises. There is no surgical fee for ankle mobility work. The revenue is in knee replacements, in cortisone injections that provide temporary relief, while the underlying mechanics continue destroying the joint, in prescription anti-inflammatories that reduce pain signals while the cartilage keeps grinding away. Your next appointment will not include a hip function assessment because there is no billing code that justifies the time it takes to do it properly. Now here is your protocol. This is not theory. This is the exact sequence I have used with patients for over a decade, and it works if you apply it consistently. You need 3 elements: hip strength restoration, ankle mobility recovery, and knee-specific decompression. I am going to give you the precise exercises, the exact repetition counts, and the daily schedule that produces results. First, hip strength. Every single morning, before you do anything else, you are going to perform the clamshell exercise. Lie on your right side with your knees bent at 90 degrees, feet together, and your head resting on your right arm. Keep your feet touching and lift your left knee toward the ceiling as far as it will go without letting your pelvis roll backward. You should feel a strong contraction in the muscle on the outer part of your left hip. Hold the top position for 2 seconds, then lower slowly over 3 seconds. Perform 15 repetitions, then switch sides. This targets the gluteus medius, the muscle responsible for stabilizing your pelvis when you stand on one leg. When this muscle is weak, your femur rotates inward and your knee bears the consequence. Second, the hip flexor stretch. After the clamshells, kneel on your right knee with your left foot flat on the floor in front of you, knee bent at 90 degrees. Your right shin should be on the ground behind you. Place your hands on your left thigh for balance. Now, squeeze your right glute, the muscle in your right buttock, as hard as you can, and gently press your hips forward. You should feel a deep stretch in the front of your right hip. Hold this position for 45 seconds while continuing to squeeze the glute. The glute squeeze is critical. It prevents you from arching your lower back, which would defeat the purpose of the stretch. Switch legs and repeat. Tight hip flexors pull your pelvis forward, which changes the angle of your femur and increases the stress on your knee. This stretch directly addresses that mechanical fault. Third, ankle mobility. Sit in a chair with your right foot flat on the floor. Keep your heel down and press your right knee forward over your toes as far as it will go. Your heel must stay in contact with the ground. If your heel lifts, you have gone too far. You should feel a stretch in your calf and in the front of your ankle. Hold the end position for 2 seconds, then return to neutral. Perform 20 repetitions on each side. This restores the ankle's ability to dorsiflex, which is the technical term for bringing your shin toward your foot. When your ankle cannot dorsiflex properly, your tibia cannot rotate externally, and your knee absorbs rotational forces it should not have to manage. Now, knee decompression. This is the element 99% of people have never heard of, and it produces results faster than anything else in this protocol. Stand facing a wall with your feet shoulder width apart. Place both hands on the wall at shoulder height. Shift your weight onto your left leg and lift your right foot slightly off the ground. Now, with your right leg relaxed and hanging loose, gently swing it forward and backward like a pendulum. Let gravity do the work. Do not use muscle to control the movement. Just let the leg swing freely for 30 seconds. The motion should be small, maybe 15 to 20 centimeters forward and back. This creates something called joint distraction. The swinging motion gently pulls the femur and tibia apart, creating space inside the knee joint. That space allows synovial fluid, the natural lubricant inside your joint, to flow into areas that have been compressed. It reduces pressure on inflamed cartilage and stimulates circulation. Switch legs and repeat. Perform this twice per day, morning and evening. Here is your complete daily protocol. Morning, immediately upon waking, 15 clamshells per side, 45-second hip flexor stretch per side, 20 ankle mobility repetitions per side, 30-second knee pendulum swings per side. Total time required, 8 minutes. Evening, before bed, repeat the exact same sequence. That is 16 minutes total per day. No gym required, no equipment required, no expensive therapy sessions. You will feel changes within the first week. The morning stiffness will decrease. The clicking sounds will reduce in frequency. The pain when climbing stairs will lessen. By the end of 3 weeks, if you have been consistent, you should experience 40 to 60% reduction in pain levels. By 8 weeks, most people report that their knees feel better than they have in years. This is not a permanent fix if you stop doing the work. Your hips will weaken again, your ankles will stiffen again. But if you maintain this protocol 3 to 4 times per week, after the initial 8-week period, the improvements hold. Now, critical warnings. If you have knee pain accompanied by swelling that appears suddenly, redness around the joint, fever, or inability to bear weight at all, that is not mechanical knee pain. That is either infection or acute injury, and it requires immediate medical evaluation. Do not attempt to self-treat that with exercises. If you have a history of knee surgery, ligament reconstruction, or meniscus repair, these exercises are generally safe, but discuss them with your surgeon before beginning. If you experience sharp pain that stops you mid-movement during any of these exercises, stop immediately. Dull muscle fatigue is normal and expected. Sharp joint pain is a warning signal. If you are currently taking blood thinners or have a clotting disorder, the increased circulation from these exercises is generally beneficial, but inform your physician that you are beginning a mobility program. If you have significant osteoporosis, the weight-bearing elements of this protocol are actually protective for bone density, but ensure you have medical clearance for exercise. Let me address the most common objection I hear. But my X-ray shows bone-on-bone arthritis. How can exercises fix that? The answer is they cannot regenerate cartilage that is already gone. But here is what most people do not understand. The pain you feel is not coming from the cartilage. Cartilage has no nerve endings. You cannot feel cartilage damage directly. The pain comes from inflammation in the joint capsule, from swelling, from bone stress, and from muscles working overtime to compensate for poor mechanics. When you correct the hip and ankle mechanics, you reduce the abnormal forces on the knee. When you reduce abnormal forces, you reduce inflammation. When you reduce inflammation, you reduce pain. The arthritis is still there on the X-ray, but your functional capacity improves dramatically. I have seen patients with severe radiographic arthritis who function better than people with mild arthritis, and the difference is always mechanical. The people who move well, who have strong hips and mobile ankles, experience less pain and better function regardless of what their X-rays show. The X-ray is a snapshot of structure. It tells you nothing about how forces are being distributed through that structure during movement. Here is what you need to understand about the healthcare system's approach to knee pain. The system is built around intervention, not prevention. There is a billing code for knee replacement surgery. There is a billing code for cortisone injections. There is a billing code for MRI scans. There is no billing code for spending 30 minutes teaching you hip biomechanics. Physical therapy gets approved for 6 sessions if you are lucky, and those 6 sessions focus on strengthening the muscles around the knee because that is what the insurance protocol specifies. Nobody has time to address the actual mechanical cause sitting at the hip and ankle because the reimbursement model does not support it. The average knee replacement surgery costs between $30,000 and $50,000. The surgeon is paid well. The hospital is paid well. The anesthesiologist cardiologist is paid well. The medical device company selling the artificial joint is paid extremely well. Teaching you 3 exercises costs nothing and generates no revenue for anyone. I am not saying knee replacement is never necessary. For truly destroyed joints with complete cartilage loss and severe deformity, it can be life-changing. But the threshold for recommending surgery has dropped dramatically over the past 20 years because the financial incentives point in that direction. How old are you? Write it in the comments. I want to see which age group makes up the majority of our viewers because it will directly shape what I cover in future videos. If this video helped you, send it to someone you care about, a parent, a friend, someone whose knees are limiting their life right now. You may have just given them a real chance to avoid surgery they do not actually need. Your knees are not your enemy. They are not failing you out of spite or inevitable aging. They are responding to mechanical forces created by weakness and stiffness in the joints above and below. Address those forces and the knees will heal themselves to the extent that remaining cartilage and tissue quality allow. You are not helpless in front of your own biology. You have more control than you have been led to believe. The only thing it requires is understanding and discipline. 8 minutes twice per day. That is the price of functional knees. Start tonight.